Hi there, I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA. I'm a medical oncologist, and welcome to this PrecisCa GI tumor board. I am joined today by a very esteemed faculty, and I'll start with introductions. Dr. Catenacci.
Hello, I'm Dan Catenacci. I'm a GI medical oncologist and director of the GI oncology program at the University of Chicago.
Hi, I'm Marty Weiser. I'm a surgical oncologist at Memorial Sloan Kettering Cancer Center in New York City.
Hi, I'm Darren Keyes. I'm both a interventional and diagnostic radiologist at the Piedmont South Imaging Center, covering 2 hospitals southwest of Atlanta.
Hi, I'm Pritesh Patel, a radiation oncologist focusing on GI malignancies at Emory University in Atlanta.
This is a 48-year-old gentleman with a newly diagnosed clinically staged cT4bN1aM0 rectal adenocarcinoma, diagnosed in December of 2020. The patient was diagnosed outside the United States and then came home for workup and treatment. And this is a very topical question now. Which sequence of treatment is most appropriate? Concurrent chemoradiation, chemotherapy, surgery, what would be the best fit for this patient? And again, there's been several studies that have read out recently that will potentially inform us. So this patient presented with bloody bowel movements and tenesmus, rectal discomfort in March of 2020. But as we've seen, I think, with recent data, that COVID has delayed medical attention for many patients. So they did not receive a colonoscopy until December of 2020 when they came to medical attention. At this time, his ECOG performance status is 1. This patient's otherwise very healthy, works in the technology sector, lives in the Caribbean, doesn't smoke or drink, really no significant past medical history, an aunt with a bone malignancy. So when he had his colonoscopy abroad, there was a 4 to 6 centimeter mass in the rectum, 5 centimeters from the anal verge. A colonoscopy was performed here in the United States and revealed this rectal mass. It was ulcerated and was diagnosed as an adenocarcinoma. Let's see, CA was 5.4. MR of the abdomen and pelvis confirms the mass and invasion of the seminal vesicles. No distant Mets. History from outside cancer center also agreed with an adenocarcinoma with no loss of expression of mismatch repair proteins. And clinically, again, it's stage T4bN1a. Biopsy revealed this adenocarcinoma to be microsatellite stable, Lynch syndrome, and hereditary non-polyposis coli unlikely. So here's the colonoscopy and the imaging. Maybe we can ask our radiologist. I think we can all look at the colonoscopy and see this mass, but maybe radiology can give us some insight from this image.
So the image on the right is a sagittal T2 weighted image from an MRI. You can see that there's a catheter tube extending, through the sphincter, and there's a balloon, is that dark black thing that injects some contrast material to help distend the rectum, so that you can see this mass. There's a low signal intensity, irregular circumferential mass, about 5 centimeters above the anal verge. Just anterior to it are the seminal vesicles. And on this single image, it's hard to tell whether they're invading, but it's certainly abutting the seminal vesicles. I don't see any evidence of distant metastatic disease. I don't see any invasion outside the muscularis. And it pretty much concurs with the findings described above.
So the discussion now is really what's the best way to manage this patient and the sequence of treatment. There's been several pivotal studies that have read out in the past few months to year, invoking the idea of total neoadjuvant therapy for these patients. But let's start with our surgical assessment. Dr. Weiser, what are you thinking about this patient in the future?
So this is a low rectal cancer invading the seminal vesicles. I do think this is a very good candidate for total neoadjuvant therapy to maximize response, to allow for a complete R0 resection. The options, of course, are to use short course radiation over 5 days or long course chemoradiation. And then you can add FOLFOX, CAPOX, or even FOLFIRINOX, as Protege did, either before or after the radiation. So there are a lot of options. Given the nodal disease, the bulky nature, I would probably favor going with chemotherapy first, but radiation first, I think, is also legitimate, as is using short course like Rapido.
So, I'll call on Dr. It's a good discussion here, but Dr. Catenacci, from medical oncology, obviously we're concerned about systemic relapse for this patient, as well as optimal local control. There's even data now that if patients have pathologic CR, it raises the question of, could we avoid surgery? How would you approach this otherwise healthy young guy who has a fairly locally advanced rectal cancer?
Yeah, I agree with Dr. Weiser. I think he pointed out all the different possibilities and options in terms of all the sequence, and there are many now, compared to sort of the 20 years ago benchmark of doing long course chemo-RT, then surgery, then adjuvant chemo. The trend to do TNT or partially move some of that adjuvant component to be preoperative, and then the sequencing of the radiation before or after the neoadjuvant chemotherapy, and then short course or long course RT. There's a lot of different variables there that can be altered. I would favor, you mentioned the PRODIGE 23 study was mentioned as a triplet chemotherapy neoadjuvantly with FOLFIRINOX. That was compared to sort of that standard benchmark German rectal study approach. And then the Rapido study, which was neoadjuvant FOLFOX, and then compared to but these are not been compared to each other. And so there is some debate as to what is the actual benefit of the irinotecan part, the FOLFIRINOX part, compared to just all total neoadjuvant FOLFOX chemotherapy. In a younger guy, like this, and who's got really bulky disease, localized disease, we might, and the other part of PRODIGE 23 is it is showing a decreased distant metastases-free survival compared to at least the adjuvant component of FOLFOX. And so there is some argument there potentially that you could go with that. So we might start with FOLFIRINOX, assess for response, and then we would discuss with radiation oncology if it's short course or long course that they are recommending in terms of the radiation component. And then hopefully if there is response, that the other component, as you mentioned there, Dr. Finn, is that if they have a complete clinical response now at that point, there is this movement in terms of, based on the Oprah study, watch and wait and surveillance. Now the survival data are not mature yet for this study yet, but certainly it looks like at least early on that's a possibility. In somebody with such advanced disease to begin with, I might be a little bit hesitant in doing that, even in that setting, and considering going and just resecting it with curative intent there. But these would be all things we'd be discussing along the way at multidisciplinary tumor board.
So I think we would like to follow a protocol, right? And PRODIGE, I think, as you both have brought up, is probably the most intense regimen with both preoperative FOLFIRINOX, radiation, and then adjuvant FOLFOX or CAPOX, as compared to Rapido, which has a shorter course of radiation. Dr. Catenacci kind of deferred it to radiation, to how the radiation would be given. What is your take, Dr. Patel? Would you strictly go by one of these protocols, or mix it up a bit? If for medical oncology we said let's try to follow PRODIGE 23, FOLFIRINOX, etc.
Yeah, so many options in a case like this. I think from what's been published on some of the newer data, it seems really, I think, short course would be appropriate really for most patients, as is long course. And some of that is really sort of institution dependent. I think the data for short course, really Rapido is probably the main one. So that's all radiation first, the short course, and then chemotherapy. I think if we are doing the chemotherapy first, most of the data is then for long course, after the chemotherapy, and then maybe a little delay to get to surgery. It seems like what we've learned from a lot of these studies from a radiation perspective is the longer you wait from the end of radiation, the more likely it is to see a really robust response. And that's probably why Rapido, which is radiation first, the German AIO study, which had a radiation first arm, showed better PAT-CR, and OPERA, same thing. You have a better organ preservation when the radiation goes first. So if we're wanting to maximize the local response, and for argument's sake, I would say this is a patient who delayed care because of COVID, still only N1 and a T4 tumor. So it seems like maybe the local problem is a bigger problem. In that case, you might make the argument to go ahead with the chemoradiation first. I tend to favor long course chemoradiation, particularly in T4 disease, because now we're wanting to go and cover a wider area, including probably the entire seminal vesicle, maybe the prostate and the external iliac lymph nodes, which is unique to T4 disease. And then give the chemo. But again, I agree. Really, both options are on the table. When we want to maximize local response, we tend to give radiation first at my institution. A lot of times that's driven by the surgical oncologist and in terms of distance to the anal verge and the need for an APR.
So as far as surgical approach, I think this was a 5-centimeter lesion from the anal verge. Assuming they have a good response, this would be a sphincter sparing surgery, correct, Dr. Weiser?
Yeah, there's no clear evidence of sphincter involvement. Seminal vesiculectomy would have to be performed, but that's pretty well tolerated. But it does involve a long discussion with patients about function, something we call low anterior resection syndrome, which is a conglomerate of stool frequency, urgency, and clustering. And patients need to be prepared for that. There's improvement over time, but that takes years and it never goes back to normal. But there would be no anatomic reason why you couldn't save the sphincters if there's a good response. Now, if there's not a good response, that is telling you that we have some poor tumor biology going on, and then I would shy away from sphincter preservation.
And Dr. Catanacci, I mean, if we went with FOLFIRINOX first, then prolonged chemoradiation, you would, well, by definition, not radiation alone, you would give chemoradiation, correct? With capecitabine, would that be?
Sure, yeah, if it was long course chemo-RT. Mm-hmm.
So like the Prodige. So I think for this gentleman who's presenting with fairly locally advanced disease that has brewed over the course of some time because of a delay in diagnosis from COVID, I think the tumor board would agree with total neoadjuvant therapy upfront, probably following something around the Prodige 23 trial, which would be FOLFIRINOX upfront for 6 cycles, and then chemoradiation, probably with capecitabine and prolonged course radiation, followed by TME, and then additional chemotherapy, probably 4 cycles of CAPOX or 6 cycles of FOLFOX afterwards. Certainly a clinical assessment before surgery could be done. And while there is the tease that a pathologic complete response may suggest that the need for further treatment after surgery or even delaying surgery or preventing surgery could be done, I think most of us feel, given the young age and aggressive presentation, that we would feel that surgery is still appropriate for this patient.